committee members. I hope everybody is well this morning. There's some crud going around, so thank you all for being here. And to the public, welcome if you're joining us online. Mr. Caldwell, if you would call the roll.
Representative Clouston.
Here.
Representative Guggenmoss.
Here.
Representative Heft. Representative McCann. Representative Ottman. Representative Stivar. Representative Wasserberger. Representative Yen.
Here.
Chairman Rodriguez-Williams. We have a quorum.
Thank you, Mr. Caldwell. Okay, ladies and gentlemen, if you did not see the handout out front of our committee room, we do have a few rules, and I'll just highlight a few of them for everybody that's here and online. Number one, please keep your cell phones on silent. That includes our committee members. Although it might seem an awkward formality, speakers will address the comments and questions to the chairman, not to individual committee members or to others in attendance. This helps us avoid personalities and comments of a personal nature. Comments will be directed at the issue under discussion by the committee. Distracting comments on unrelated side issues are out of order. Speakers will avoid personal criticism, ridicule, or name calling directed at anyone else in attendance at the meeting. This includes comments of a personal nature directed at other speakers, audience members, or members of the committee. For audience members, we expect you will refrain from any behavior that disrupts the orderly conduct of the meeting. Specifically, the rules prohibit speaking out loud when another person is talking, carrying on loud and distracting side conversations, any shouting, clapping, booing, woo-wooing in response to other speakers' comments. Our general guideline is simple, that everybody conducts themselves in a civil and respectful manner at all times during the meeting. This morning, we will have 3 bills to consider. We will be hearing House Bill 195, House Bill 274, and then if time permits, House Bill 222. So with that in mind, House Bill 195 is on the table for consideration. The bill is titled Credit Reporting Medical Debt and is sponsored by Representative Provenza. Welcome, Representative Provenza. Good morning.
Good morning, Madam Chair. Thank you. Thank you, members of the committee, for your thoughtful consideration today. I bring to you today House Bill 195, Credit Reporting Medical Debt. Madam Chairwoman, this is an issue that is near and dear to my heart. My father died in September of 2024 after refusing an ambulance because of his concern about debt. And it is something that I have also lived with. I have gone through medical debt collections issues, and while I settled that debt, I am still trying to fix my credit because of that debt. So, and I'm not alone in that, Madam Chairwoman. This is something that 15% of Wyomingites have dealt with, and the median medical debt amount in collections for people in Wyoming is $1,500. So this is something that really impacts a lot of your constituents as well. In addition to that, 1 in 3 people have medical debt, and your credit score number can really impact a lot of opportunities that can be allotted to you. So an instance in my case, I'm not on my mortgage with my spouse because my medical debt impacted my credit score. It impacts people's ability to get housing, as landlords often will check your credit score. And I would submit to you as well that it also can impede in what opportunities you have for employment. So employers sometimes check your credit score. And while there might be reason to use your credit score to, say, give you a loan and things like that, I would ask, is cancer one of the reasons that you might not be able to get housing? And oftentimes that is the case. As people spend through their savings, they often have to rely on credit and debt to be able to pay their medical bills. So what I've brought to you today is a bill that would prohibit medical debt from being sent to credit agencies. which could improve credit scores for people with medical debt by up an average of 20 points, which is pretty substantial. So what this bill does, and I'll walk you through it, Madam Chairwoman, on page 1, line 11, we're creating a new statute in our consumer protection laws. So Title 40 is Trade and Commerce. Chapter 12 is Consumer Protection, which is where this is housed. When you get to page 2, line 1, we're talking about new definitions. So a collection entity means any person that purchases medical debt from or collects medical debt on behalf of another person. And then we talk about what credit reports are. This is current law in 40, in Title 40, Chapter 12, 501, AIV, Consumer Reporting Agency that determines your credit worthiness. And then we have another new definition on line 8 through 10. Credit reporting agency means a person that collects and sells information about a person's credit history. Healthcare products is lines 12 through 15. So this is including but not limited to a good device, durable medical equipment, or prescription drug provided in the provision of healthcare services. Healthcare services are defined in Title 26, 13303. And as a quick overview of that, it is defined as healthcare services that are used to diagnose, prevent, treat, cure, or relieve a health condition, illness, injury, or disease. On lines 20 through 23, medical debt means an obligation or alleged obligation of a consumer to pay any amount related to the receipt by the consumer or healthcare products or healthcare services. This medical debt, importantly, shall not include debt that is charged to a credit card unless that credit card is issued under an open-end or closed-end credit plan offered specifically to pay for medical debt. So this just means if you use your credit card to pay off your medical bill, then that is not debt. Like we can't do anything about that. That is debt that's on your credit card that will be tracked by the federal credit agencies. But oftentimes you'll see when you go to pay your bill, they might offer you a medical credit card at time of service. That is a different entity, and you might see some definition changes brought to you today by some people that might testify, and that will be a policy decision that'll be brought to you in terms of whether you want to include those medical credit cards or not. Medical facility, hospital, clinic, office, etc. And then subparagraph B on page 3, here we're saying that each medical facility and collection entity doing business in the state of Wyoming shall not report any portion of a medical debt to a credit reporting agency for use in a credit report. So this is the clause that says that we can't report medical debt and harm your credit score. On line 16, if this is the provision that says what happens if you do, so it's the enforcement mechanism, Madam Chairwoman. If a medical facility or collection entity violates this section, a court of competent jurisdiction may impose a civil penalty. So this is saying that the courts can decide that there's a civil penalty involved, and it would go through our current process of our courts. Originally in this bill, I put in that if you did that, then your medical debt was cleared. That was perhaps, I thought maybe a step too far for the legislature, and brought constitutional concerns. This is something that it fits that and fits within our laws. So we should be good to go on that. Other states have implemented this. So you might hear today from people out of DC that that banning credit reporting to credit agencies for medical debt is problematic. Other states have done this, and there have not been any lawsuits against those. One of those states is Texas, I think was kind of the spearhead for this. So this is not brand new, Madam Chairwoman. It's been tested and so far has been holding up. So that is my good little bill, Madam Chairwoman, and I would stand for any questions.
Thank you, Representative Provenza. Committee, any questions for the bill sponsor regarding the content of her bill? Representative Wasserberger.
Thank you, Madam Chair. Thank you, Representative Provenza, for proposing this bill. I'm just curious, has this caused any types of issues with our medical providers being able to stay in business and things like that, of that nature? Has it increased the costs on those that actually are paying their bills?
Representative Provenza.
Madam Chairwoman, as far as I know, no, I have not heard from anybody that has said it has put them out of business. I think you'll probably hear that some folks like to use this as a stick to say, well, you got to pay your bills. That might be valid. It might not be. I think the reality is that most people want to pay their debt. People value that they are hardworking people. They want to do what they can, and there's still other means of collecting that debt. It's just not that it goes through your credit score.
Representative Clauston.
Thank you for being here this morning and sharing your personal story. My personal story is on the other side. I have a couple PT clinics. Yesterday, we had 9 people who have not paid their bill in a year. We're at the end of the month. So called all 9. 4 of them paid it in full. 2 of them set up payment plans. And these are all people who haven't paid their bill for over a year. The other 3 just didn't pick up the phone. So I will agree with her that it's really the threat of going to collections and having it affect your credit score is what helps people pay their bills. And, you know, most medical facilities, we're seeing an 8 to 9% decrease in what we were paid last year on our claims. So healthcare is tough, you know, and you start taking away another tool maybe to try to get people to pay their debts. Without people paying their bills for the services they receive, we'll see hospitals affected, clinics affected. So I think the federal government has done a lot of things to try to work on this issue. I just think losing this tool to help our clinics and hospitals would be a mistake in Wyoming. Ms. Provenza, if we lost this ability with credit and collections, do you have another way that medical providers could get people to pay for their services they received?
Representative Provenza.
Thank you, Madam Chairwoman. Representative Clausen, you would still have the ability to use the courts to try and impose the debt be paid. So there's nothing barring you from using the other mechanisms that are still in place to collect debt. You just wouldn't be able to report it to the credit agency and harm people's credit scores.
Follow-up, Representative Clauston.
Thank you, Madam Chair. Thank you, Representative Provenza. So I understand we have that, but now we're increasing costs again, just to try to go to court and to collect these, hire attorneys. So do you see any other way we could do this without incurring more costs to try to collect on debt?
Representative Provenza.
Thank you, Madam Chairwoman. You know, I would push back that this is going to increase the cost of medical care. You know, there's a lot of things that would decrease the cost of medical care. Someone's credit score is not one of them. If you said you had 8 or 9 patients, I would ask you, how many patients do you have total?
Follow-up, Representative Clauston.
Thank you, Madam Chair, and thank you, Representative. So my comment towards the cost is if I have to hire attorneys and go to court to try to collect that debt, that's the increased cost there. So that does increase my costs to a clinic or any hospital facility doing that. And again, the 9 that I'm talking about, these are people that have received multiple letters, phone calls, right? That this has been over a year. They haven't made any payments for a year. So they've been offered payment plans. So this is really our final step. So number of patients, I mean, we have hundreds, right, every week. These are people that we've tried to work with for a year.
Representative Provenza.
Madam Chairwoman, Representative Clausen, I would subject to you that I don't think a threat of their credit score is going to be the thing that makes them pay that bill or not. They are already aware. So I don't see how, if they haven't paid for a year and they haven't made a payment plan with you, that then threatening them with the credit bureau is going to be the thing that gets them to pay. I think they probably are unable to pay you.
Representative Yin.
Madam Chairman, thank you. Representative Provenza, a provider still has the ability to sell their debt to a collection agency or even threaten to sell their debt to a collection agency. Is that correct? They just can't sell it. They just can't give that data to the credit reporting agency, but they can still sell it to a collection agency.
Representative Provenza.
Madam Chairwoman, Representative Yin, that is correct. So the other mechanisms are still in place. It's just the credit score reporting that is prohibited.
Committee, any additional questions? Vice Chairman Ottman.
Thank you, Madam Chair. Representative Provenza. So as they are not able to pay, and I understand that with the cost of a lot of things, are they subjected then to make a payment plan or just write it off? Is there anything that helps with that?
Representative Provenza.
Madam Chairwoman, I did not tackle any of that in this bill. I kept it real narrow to that credit score. That is up to essentially the provider. And you might hear from some folks today that could talk to you more about that. Sometimes the debt collector might be willing to work with somebody. It might be that they're not, and they sell that debt off, and then a company buys it, sometimes for pennies on the dollar, and then you'll get phone calls, 10 times a day. I don't know if you've ever had a debt, Representative Ottman, but the means at which they'll try to get a hold of you are substantial. And then, of course, they still have the judicial process to invoke if that is not met, and then you'll be contacted via subpoena.
Additional questions of the bill sponsor? Okay, seeing none, thank you, Representative Provenza, for joining us. Don't go far. Okay, we will move on with public comment. If you plan on testifying on House Bill 195, credit reporting medical debt, I just ask if you raise your hand. Okay, so 1, 2, 3, 4, 5, 6, 7. We got 7 in the audience and about 4 online. So we will, I'll just ask that everybody keep their comments succinct, their testimony succinct, and if somebody before you stole your thunder, offer something new in regards to the bill. We will take public comment from government agencies first. So please come forward if you're with a government agency. Okay, see none, and there's none online from government agencies. We'll open it up to the public. We've got 3 chairs up here, so come forward. Good morning. So, sir, please state your name, whether or not you support or oppose the bill, and if you can keep your testimony around 10 minutes, the committee would appreciate it so we can hear from everybody.
Absolutely,
So,
Madam.
thank you, sir.
Madam Chairman, members of the committee, my name's Dave Pickard. I'm representing the Receivables Management Association International. Neither support or oppose the bill, fairly neutral on it. As Representative Provenza described the bill, this type of public policy is being adopted in many states for the purpose of not having medical debt reported to the credit agencies for credit scoring purposes. It doesn't prevent any of the providers the ability to go and try and collect that debt or assign or sell that debt to a third-party collector. This is simply about what can be included in your credit report that is used for the credit scoring. So with that, Madam Chairman, there is a proposed amendment in front of you. I hope it has been distributed. It's very straightforward. What the Receivables Management Association looks for in these type of bills is consistency throughout the state so that we don't have a whole big book of what can and cannot be reported in individual states that go into your credit score. Our credit is migratory. It doesn't know any state boundaries. So what we try and do is make sure that there's a consistent definition in these types of bills. And with that, Madam Chairman, I will direct you to the amendment. It simply is defining medical debt a little bit differently than how Representative Provenza has this currently in the bill. So at page 2, line 20, we would strike the entirety of section Romanet 6 and insert the definition. Medical debt means a debt owed by a consumer to a person whose primary business is providing medical services, products, or devices, or to the person's agent or assignee, that's collection agency or the third party, for the provision of medical services, products, or devices. Medical debt includes but is not limited to medical bills that are not past due or that have been paid. So the whole plethora of medical debt is included in this. And what I would like to say about the current definition, two pieces in there are of concern, and that's why we're bringing this standardized definition. The first one, where medical debt means an obligation or alleged obligation. So the alleged obligation could mean that the consumer is saying that a portion of my home equity line of credit was used for medical purposes, and therefore it should not be reported. So there's pluses and minuses to the consumer on that. Most people that have their home equity lines of credit in a current nature is a very positive for their credit score. Those that might be in arrears could have some negative effect on their credit score. But the fact is that X thousands of dollars of home equity line of credit might only have $500 of medical devices in there and $7,000 worth of home improvements. And so we feel that the overwhelming nature of having to understand what portion of home equity lines of credit, I use as an example, are medical debt. That's the purpose of the amendment that we have in front of you. And with that, Madam Chairman, members, I'll stand for any questions.
Thank you, Mr. Pickard. Any questions from the committee? Okay, seeing none, thank you for being here and for your testimony. Good morning, ma'am. Please state your name and whether or not you oppose or support the bill, and we'll hear your testimony.
Good morning, Madam Chairman. My name is Rebecca Bexdale, and I live in Jackson. I'm not actually here to support or be against this bill. I'm planning to testify about another bill, but there were a few things that Representative Provenza said that struck me, and also Representative Clausen, and I just wanted to touch on that. My fourth daughter, Hannah, has a very rare genetic disorder. Only 75 people in the world have what she has. And when she was 3 months old, I knew that there was something wrong. We didn't know, everyone kept saying everything was going to be okay and that she was fine. And I was trying to talk my family into going to church, and all of a sudden she passed out, and a long story short, she was life flighted to Salt Lake City and was intubated for 21 days and there for 28 days. And that's when we learned that she had a problem with her brain. But I understand that people need to pay their bills, okay? It's frustrating when you see people pull up at the hospital in really expensive cars that you can't even afford, and they don't have insurance, and then they can't pay their bills. I can understand where that's frustrating. But in our case with Hannah, the bill was hundreds of thousands of dollars. And for example, she had to be on morphine, and they were charging $100 per dose for something that should cost less than $1. And a lot of these, they kind of have you hostage in these hospitals with infants because you can't go shop around. Wherever you land is where you're going to be until your child gets better. And so on the one hand, sure, people need to pay their bills. People need to be responsible. I'm not arguing that. I pay my bills. But someone like Jonathan and I, we work hard, we have insurance, but my insurance did not want to pay this bill because we were over a barrel and it was obnoxiously expensive. So when my insurance didn't pay it, guess what that means? I have to pay it now. And that could have caused me to not buy a house. That could cause me, and and how I'm being charged is unfair. So I just wanted to say both sides of the story. There is the side of the story where you just signed up for physical therapy and now you're not paying the bill. And there's another side of the story where your child almost died and you didn't have a choice at a provider and you landed somewhere. And at one point I had to just quit looking at the bill. They would come in there and your kid, they told me my child had a 30% chance of not making it by the end of the week. So you just have to let it go. And you just have to hope that everything's going to be okay and you had good enough insurance. I yield the rest of my time and I'll take any questions. Anybody has any?
Committee, any questions for Ms. Bextel? Representative Yin.
Madam Chairman, thank you, Ms. Bextel. Nice to see you. So you'd basically characterize medical debt as a type of debt that sometimes you have no choice in the matter. You end up just getting saddled with it, as opposed to other types of debt where you buy a car, you chose to do it. Student debt, you chose to go to school, you chose to take out debt for that. Is that how a good characterization?
Madam Chairman,
Ms. Bextel.
I'm not saying that you don't have a choice. You have a choice. People can get insurance, and I was fully insured. I guess sometimes people, when Representative Provenza said, if you get cancer, does that disqualify you now from, that is true. That is true. You could get cancer and it could wipe out everything. And so I certainly, all I did was have lots of medical insurance. I'm fully insured. I'm a small business owner. You probably can't get more insurance than I have. And, but I still didn't have enough to cover all that. And I earn a good living. And I'm certainly in a financial position to be able to, afford what I need. But I wasn't planning on a child being in a hospital for 28 days at $100 a hit on something that should cost less than $1. So it is a complicated situation. And I know, I feel like the constituents are in excellent hands this year in the House. And so I know y'all are going to do the right thing. I yield my time.
Thank you, Ms. Bextel, for sharing your story. Sir, please state your name and whether or not you support or oppose the bill, and we'll hear your testimony.
Madam Chairman, Bill Winnie, Sublette County. I support the bill. And to follow on the heels of Ms. Bextel here, I'd like to give you another perspective on medical debt. I'm a disabled veteran. I'm over 50%. Thus, the VA took over my health care. Being retired from active duty, a career, I was under TRICARE Medicare, and my wife is now under the TRICARE Medicare system. As I look at the billings that come in that the VA or TRICARE is going to pay, and then what they really pay, there is a vast difference. The billings are far bigger than what they're going to get. Well, the good news is those institutions agreed to accept that as full payment, so I don't incur any debt on it. The issue is industry offsetting. This is what Ms. Bechtel was talking about, is where they take that other 80–90% of the billing and transfer it over to somebody without insurance, or $100 a dose for something that really costs maybe $1 to manufacture. I had a close friend out in Jackson who has now passed away, Naval Academy graduate, and he had diabetes. And he'd had it for a long time. And he remarked to me one day, when I first started taking insulin, it was like $5, $6 a dose. He would periodically inject himself. He said, now I'm paying like $600 a month for this stuff. So you need to keep in mind an industry issue that people are facing. Again, this is what Ms. Bextel was talking about. My wife recently, in the last 3 years, had 2 knee operations, 2 back operations, and then she slipped on ice and crushed her wrist, so she had her wrist operation. Those are the kind of things I'm talking about when I talk about the industry offsetting and what I see in the bills and then what is paid. I had a close friend here in Cheyenne who had a granddaughter that he had to care for significant, that incurred significant billings, and he was a business owner. He had the money to pay. He did pay, but what he did was he went in, and this is here in Cheyenne, to the business office and said, okay, what's your bill if I write you a check right now? They whacked 20% off the billing right there on the spot because he was going to give him cash. That's an administrative overhead issue. So subject to your questions, Madam Chairman, I thank you for your time.
Thank you, Mr. Winnie. Any questions for Mr. Winnie from the committee? Seeing none, thank you both for joining us today. Anybody else want to come forward? There's 2 open chairs. Please state your name and whether or not you support or oppose the bill, and keep your testimony to around 2 minutes, please. Thank you.
Certainly. Thank you, Madam Chairman, members of the committee. Josh Hannis with the Wyoming Hospital Association. I'm really just going to offer a few comments and then some perhaps other suggestions on how to deal with this issue of medical debt more proactively. So what are some of the drivers of medical debt? One of them is that, and particularly in Wyoming, we have a very high rate of uninsured residents. It's about 12.9%. In 2023, the national average is 9.5. There was only 4 states that had a higher uninsured rate than Wyoming in that particular year. Things like high deductible plans subject many people to cost sharing they can't afford. And there's certain plans that provide inadequate benefits that often lead to surprise charges. I will note for the committee that hospitals are the only part of the healthcare sector that provides services to patients regardless of their ability to pay. We help them enroll in federal and state programs that they might be eligible for. We provide financial assistance. And in doing so, our hospitals absorb about $140 million a year in care that's not in uncompensated care to our facilities. Insurance companies get their money, drug manufacturers get their money, medical device manufacturers. We shoulder the burden of patients who are unable to pay. So, I'd also note, there are federal laws about how our tax-exempt hospitals have to go about their collection practices that gives up to 240 days to apply for charity care and other things like that. So I guess what I'd offer is, what are some other policy levers at your disposal that could help prevent medical debt altogether? Let me rephrase, not altogether, but how could we mitigate medical debt? One would be restricting the sale of high deductible plans unless somebody can demonstrate that they can afford that gap. Prohibit the sale of health sharing, of health sharing ministry products, which don't provide any coverage and may not pay for services at all. And then you can remove providers from the collection of cost sharing that insurance companies place on us. So they set, if you're insured, your deductibles, copays, and then we're required to collect those. In a more efficient situation, insurance companies would pay the bill, and then if there's a cost sharing or deductibles, the insurance companies can deal with their members to collect those, and then that would remove most patient bills from providers altogether. So just a few things to consider, and I'm happy to answer questions.
Thank you, Mr. Haynes. Any questions for the Hospital Association? Representative Wasserberger.
Thank you, Madam Chair. Thank you for sharing some of the suggestions that you have for the issue. I just, listening to some of the things you said, I'm just wondering, are you familiar with if there's like any type of charities out there that do some type of pool sharing to kind of help with mitigating medical costs and things like that, that people maybe donate to, or?
Madam Chairman.
Mr. Haynes.
Representative Wasserberger, I know there are some fairly large and well-funded nonprofits in other states that purchase medical debt to wipe it clear from the patient's responsibility. I can research and find more details about how exactly that looks, but I am generally aware that that exists.
Thank you. Okay, seeing no other questions, thank you for your testimony. Sir, please state your name and what organization you're with, and keep your testimony to around 2 minutes, please.
Madam Chairman and Committee, I'm Tom Laycock with AARP Wyoming, membership organization for adults age 50 and over in the Cowboy State. I'd like to offer our support to the bill and thank the sponsors for taking the time to address the concern. Medical debt's a widespread problem, with roughly 1/5 of households reporting having medical debt, according to the Consumer Financial Protection Bureau. That report found that consumers carried more than $88 billion in medical debt on their credit reports in 2021, and that 58% of debt in collections on credit reports were due to medical debt. Although medical debt's a problem for people of all ages, adults age 50 and older are particularly affected. They're more likely to need expensive medical treatments. More than 44% of people age 50 to 64 and 22% of people age 65 and older carry medical debt. Medical debt on credit reports, as we've learned today, can lower credit scores and impair people's ability to obtain loans, employment, housing, and insurance. So for that reason, It's AARP policy that medical debt should be excluded from credit reports, that consumers should have the right to a fair appeal process to address complaints and grievances. That said, I'll stand for questions and get out of your way.
Thank you, Mr. Laycock. Any questions from the committee for AARP? Okay, seeing none, thank you. Good morning. Please state your name and who you're with, whether or not you support or oppose the bill, and keep your testimony to around 2 minutes, please. Thank you.
Thank you, Madam Chairman, members of the committee. Scott Meyer on behalf of the Wyoming Bankers Association. This will be short. We neither support nor oppose the bill, but we support the amendment that Mr. Pickard brought forward. Stand for any questions.
Thank you. Any questions from the committee? We're a lively bunch, huh? Thanks for your testimony. Good morning. Please state your name and whether or not you support or oppose the bill, and we'll hear your testimony. Then we'll move to online afterwards.
Good morning. My name is Micah Richardson. I'm with the Wyoming Women's Foundation, and we are in support of this bill, but are also open to learning more about what other options there are out there. As other people have noted, and as Representative Clauston noted, we don't want to leave some of our smaller providers in Wyoming high and dry. However, we also realize that medical debt is a real big issue, and it hits women harder typically than it does men. Women tend to have a higher deductible and usually have lower income, especially in Wyoming. And so this, women typically pay 18% more on average in annual out-of-pocket costs, and that excludes pregnancy-related services. So we are really hoping to find some sort of support that can help, especially women who find themselves in these situations. I'll leave it at that.
Thank you. Any questions for Ms. Richardson from the committee? Okay, seeing none, thank you. Mr. Caldwell, we'll move to online. I think we have one registered?
There are three.
Three. Oh.
The first is Adam.
Okay. Good morning, welcome, Mr. Zarin. If you unmute yourself and state your name and who you're with, then we'll hear your testimony. If you'd keep it to 2 minutes, please.
Yep.
We can't hear you. Now we can. There we go.
Okay, sorry about that, Chair. My microphone was working. My name is Adam Zan. I'm from the Leukemia and Lymphoma Society. We're in support of HB 195. We're a national nonprofit trying to cure blood cancer and also improve the quality of life for patients and their families. I just want to reiterate some of the things that Rep. Provenza said. Again, 1 in 3 Americans has a personal experience with medical debt, and right now, 15% of Wyomingites has medical debt in collections. And this is mainly due to healthcare prices increasing over the years, and that even with insurance, individuals face increasing out-of-pocket costs like deductibles and copays. So the solutions that Mr. Haynes propositioned earlier, we would agree with, but are not the focus of this bill. For those with chronic illnesses like blood cancers, those costs will pile up. For example, in the first year after diagnosis of acute leukemia, a patient can pay almost $500,000 in medical bills. So, we feel medical debt is fundamentally different from other types of debt. No one applies for or chooses to get sick or have a medical emergency. And medical debt is often riddled with billing errors, forcing individuals into collections or payment plans for bills that they don't actually owe or should have been covered by insurance. So again, we think that this is a common sense, nonpartisan solution to help patients and individuals manage their medical debt and move on into the future. Happy to answer the questions, but thank you for the time, Chair.
Thank you, Mr. Zarin. Any questions from the committee? Okay, seeing none, thank you for your testimony and joining us this morning.
Next is Zachary Taylor.
Okay. Good morning. Good morning. Please state your name, who you're with, and whether or not you support or oppose the bill, and keep your testimony within 2 minutes, please.
As you wish, Madam Chair. My name is Zachary Taylor. I'm the Director of Government Relations for the Consumer Data Industry Association. We represent the consumer reporting agencies, the 3 nationwide credit bureaus, specialty reporting agencies, background check companies, and tenant screeners. We are opposed to HB 195, which would prohibit the reporting of medical debt to consumer reporting agencies we represent by a medical facility or a collection entity. We are sympathetic to many of the concerns raised today as it relates to medical debt. However, this proposal, as we've heard this morning, would do nothing to address the underlying cost of care. However, this does open the door to unintended consequences for Wyomingites, as the accuracy, completeness, and reliability of consumer reports in Wyoming could be harmed by the deletion of information that helps lenders make determinations about a person's ability to repay and the creditworthiness. I'll also note that the proposal here is preempted by the Fair Credit Reporting Act at the federal level, because it does restrict the furnishing of information to consumer reporting agencies. This has been found by federal courts in the past to be preempted, that the reach is broad and explicit. And I would also add that it also, right now, as you may be aware, the Consumer Financial Protection Bureau in DC has issued regulations related to this matter. Those regulations have not yet been adjudicated, but if they were to be held, this bill would be in some ways unnecessary because there'd be federal prohibitions against the reporting of medical debt. Short of that, I did want to correct some misconceptions, if I could quickly, as it relates to medical debt and consumer reports. The companies that we have represented for many years have changed some of their procedures as it relates to medical debt. As of today, amounts less than $500 will never appear on a consumer report. Amounts greater than $500 that are less than a year old will not appear on a consumer report. Amounts that are in a payment plan will not appear on a consumer report. This year-long period provides consumers with time to work with providers and insurers to correct errors in billing or find a way to ensure that their insurer pays what they're supposed to. However, unpaid debts do exist and may find their way onto credit reports. However, these changes have made significant impact in the amount of debts on consumer reports, removing a substantial majority of those amounts from consumers' reports. Also, we heard a lot of talk about credit scoring. Credit scoring and consumer reports are two different products. However, many credit scores have adjusted how they consider medical debts.
Mr. Taylor,
Yes.
you are out of time, unfortunately.
Oh, okay. Well, I'm sorry.
If you have additional things you'd like the committee to know, I would encourage you to email us.
I submitted a letter this morning outlining in greater detail the preemption issues with this bill, and also would note we look forward to reviewing the amendment offered by the Receivables Management Association, as that could open the door to additional challenges in the definition. Thank you for your time, Madam Chair and members of the committee.
We did receive that letter, so thank you. Okay, next. Okay. Good morning, Ms. Shaver.
Good morning. I'm Marcy Shaver from Goshen County. I wasn't going to speak on this bill, but I once worked in one of those credit reporting agencies, and the people who wanted, that were researching would-be customers, weren't interested in medical debt because it can take so long for that to clear with insurance. So they didn't want it in the report. And then years later, I worked as a bill collector for a credit union, and the medical debt could impact everything else. And, I'm calling about a car payment, and because the hospital's pressing them so hard for payment, they can't meet their car payment. So it's when you get hit by huge medical debt, it just impacts your entire life, not to mention the life-threatening things that can come from that. So I stand very much in favor of this bill.
Thank you, Ms. Shaver, for your testimony. Any questions from the committee? Okay, seeing none, thank you for joining us this morning. That's it, okay. All right, so I will close public comment on House Bill 195. Representative Provenza, if you wouldn't mind coming back up. Okay, committee, what is your pleasure on House Bill 195? During discussion, if the bill gets moved?
Move the bill.
Okay, the bill 195 has been moved by Representative Yin. Second by Representative Gugamas. Okay, discussion on the bill. Committee, you guys have a few amendment handouts as well, so this would be the time to move any amendments as you discuss the bill as well.
Madam Chairman,
Representative Yin.
I'll move the amendment proposed by Mr. Pickard.
The amendment by Mr. Pickard has been moved by Representative Yin, seconded by Representative Gugamas. Discussion on the amendment. And you can ask the bill sponsor at this time too if you have any questions regarding the amendment. Representative Yin.
Mr. Chairman, I mean, I think I agree with Mr. Pickard. If you choose to move that into another debt tool that you've already agreed to, that was a choice that you made. So I'm fine with excluding that with the amendment. So that's all.
Further discussion on the amendment? Okay, seeing none, all those in favor of Representative Yin's amendment, please by a show of hands and by an aye, state aye. Aye. All opposed? Okay, that amendment has passed, and Mr. Caldwell, you have a copy of that? All right, additional amendments, additional discussions on House Bill 195. Vice Chair Ottman.
Thank you, Madam Chair. Representative, what, or does this cover elective surgeries? Like sometimes you can get very expensive elective surgeries. Thank you.
Representative Provenza.
Thank you, Madam Chairwoman, Representative Ottman. That's a great question. So the bill refers to 26-13-303 AII, which is, this definition here has essentially, my understanding of this is that this definition excludes things like cosmetic procedures unless they are part of the standard medical care. So in a case like a patient gets breast cancer and they want to go through cosmetic treatment afterwards that deals with some of the issues that you can see in that treatment, a breast cancer survivor would be able to be protected by this language, but it wouldn't cover things like Botox or facelifts or anything like that.
Follow-up, Vice Chair Ottman.
Please, Madam Chairman. Representative Provenza, can you tell me what page that's on again?
Madam Chairman.
Representative Provenza.
Representative Ottman, it's on page 2, line 18. That's 26-13-303A. That language isn't in your current bill. It's referring to current law. But I can read that for you. Nope, I grabbed the wrong green book. If you would like, I'll grab my green book and read that definition to you.
Additional questions or discussions on the bill from the committee? Representative Yin.
Madam Chairman, so, I did read the CDIA letter, and I looked at the court case they mentioned about the federal preemption. So the court case had to do with regulating the agency, the consumer reporting agency themselves, and telling them what they could and couldn't put in there. This bill is different, so it tells providers that they can't report to the credit reporting agency. So I think the preemption issue, this bill doesn't fall under that specific court case.
Additional discussion on the bill. Representative Gugamas.
Thank you, Madam Chair. I don't know if I'm missing something here. It looks like this bill is just specifically aimed at medical debt being reported for credit score situations, to where if somebody has major medical debt, the credit score agencies cannot dock them for that when they're trying to, say, buy a house or something along those lines. And I guess I'm kind of confused, because then we have all these collection debate and talk on how that would affect collecting. I guess I'm not exactly sure how that ties in I must be missing something if that could be clarified.
Would the bill sponsor like to answer that? Representative Provenza.
Madam Chair, I think that there's concerns about that, but the intent of the bill, and to the best of my understanding, is is exactly how you stated. It keeps the collector, the person who now owns the debt, from reporting the debt to the credit agency, so that the credit agency, because how your credit score is determined in part has to do with how much debt versus your income, right? So if I accrue $100,000 in medical debt, even potentially if I'm paying or whatever, which I don't think they'd report it as we heard, but in the event that maybe I'm struggling to pay that $100,000 off, which I would, Representative Guggenmoos, then that is when we see this catch-all of like, okay, you have $100,000 in debt, but you make $50,000 a year. That is what the intention of the bill is doing and what I believe that it is doing. There's nothing that says you can't collect debt. There's nothing that says you don't have to pay your bills. This means that your credit score won't be impacted by your medical debt, which I would submit to you that for an example of a $300,000 mortgage, a 20-point increase in your credit means that you could save $15,000 over 30 years. So it is an opportunity for economic freedom for people that have things like cancer that they did not choose.
Okay, committee, any additional comments on the bill? Representative Klauston.
Thank you, and I mean, very sympathetic to this, and just want to talk a little bit about a question that came up earlier. So, phone calls yesterday, 9 people, debt's out there for over a year. When we told them, this will affect your credit score, 4 of them paid it in full, right? The other 2 set up payment plans. And for a year, they haven't paid their debt just because there was no consequences. So that's how it affects a provider, right? Very sympathetic to these people. I mean, we really have underlying issues here, right? We have increasing insurance costs, increasing deductibles, and then your providers are being reimbursed less. So that's part of the problem here. Like, this bill doesn't address either one of those issues, and it can't, right? Those are separate issues. But to me, I'm not comfortable with this. If someone wants to go buy a car and they have medical debt, that bank or credit union or car dealer needs to know that there's other debt out there. Otherwise, this person's gonna go buy a car and now they're gonna have more debt that they probably can't afford. So I think there's just some other considerations here, and I'm very sympathetic to the bill and these people. I think there's some underlying consequences that we're not really considering.
Additional discussion before we vote. Representative Yin.
Madam Chairman, so I have a friend who is a landlord, and they have a tenant who has a lot of medical debt. That tenant was homeless for over a year before that landlord took a risk on them. The reason that tenant was homeless was because they had an insanely low credit score. That credit score was because their wife died of cancer. And so they were saddled with the medical debt from their wife. They have a good job. They can pay their bills. They have medical debt that gave them a low credit score, and they were literally in a homeless shelter. So it does impact people very dramatically, and it really is no fault of their own. This provides people access to opportunity that they would not normally be able to have unless someone dove deep and said, oh, that's the reason you didn't have a choice in the matter. But if people automatically filter by the credit score number, which we know they all do, then they don't even get their foot in the door. So I'm going to vote aye.
Additional discussion. Representative Wasserberger.
Thank you, Madam Chair. This is something that's been discussed for a long time, is the cost of healthcare. And I mean, I would imagine almost everybody in this room can agree on that there is an issue with the cost of healthcare. One of the so I guess to maybe push back a little bit on this, I mean, I do agree that we need to find a solution that's better than what is currently happening. But I know that we just worked on getting a bill passed that would allow for pricing on, medical needs, and I would imagine that competition is going to help lower those costs. The other concern I have with this is just for some of your small firms, we've passed a bill back in the day, back in, I think that was 2012, 14, the Affordable and Quality Care Act. And one of the concerns with that bill was I watched a lot of the small pharmacies in my area, go out of business, but your bigger companies were able to absorb that cost and were able to suck up a lot of that small competition. So that is kind of the concern I have with this bill at this time. But I mean, I guess with the current bill that we passed to allow for the pricing of medical services, I think at this time, I'm gonna have to be a no vote for the time being.
Okay, committee, sensing the urge to vote. All right, Mr. Caldwell, if you'd please call the roll on House Bill 195.
This is a roll call vote for House Bill 195 as amended. Representative Klauston,
No.
Representative Guggenmoss,
Aye.
Representative Heft, Representative McCann, Representative Ottman,
Aye.
Representative Stivar, Representative Wasserberger, Representative Yen,
Aye.
Chairman Rodriguez Williams. Madam Chairman, that is 3 aye, 5 no, and 1 excused.
Okay. All right, committee, I am going to switch up the order of the bills that we had here. And I'm going to move up House Bill 222, Medical Ethics Defense Act. Representative Ottman is our sponsor, is the sponsor of the bill. And she has some folks that have traveled out of the area and a co-presenter as well online. So I'd like to give her the courtesy to hear that bill first. So Mr. Caldwell, her co-presenter is online by the name of Greg, Mr. Shuffin. Okay, not online. All right. I've got, did he sign off? He's on the list here. Okay, all right. Okay, Representative Ottman. Do you have
Thank
another?
you, Madam Chairman, committee. Today,
Representative Ottman, would you like your other co-presenter to come up?
Oh,
That's
yes.
not online? Okay.
Thank you,
so
Madam
we have one
Chair.
more. Okay. All right, committee. House Bill 222, Medical Ethics Defense Act is now on the table. Welcome Representative Ottman and your co-presenter. Please state your names and introduce to us the bill.
I'm Dr. Dean Bartholomew. I'm a family physician from Powell, Wyoming, here representing myself.
Thank you, Madam Chairman and committee. I'm sorry. Whatever was going around yesterday, I caught it. And so I'm having just kind of a hard time thinking. So anyway, thank you, Dr. Bartholomew. Yes, and yeah, I would do that. Okay, I bring to you House Bill 222, Medical Ethics Defense Act 2. This bill protects the conscience rights of medical professionals, which are desperately short which we are definitely short of in Wyoming. I'm bringing this bill because every American should have the freedom to live according to their ethical and religious beliefs, and this includes our medical professionals. 9 out of 10 doctors of faith say they would rather stop practicing medicine than violate their ethical, moral, or religious beliefs. 1 in 5 medical students say they have chosen not to practice in a certain field because of hostility towards their beliefs in that area of practice, many of them aspiring OBGYNs, which Wyoming is lacking. This bill will protect Wyoming's healthcare professionals and help attract more to our state. I can walk you through the bill now. Okay. Beginning on page 2 and going through page 5, you'll find definitions of the term conscience, discrimination, healthcare institution, healthcare payer, healthcare professional, and healthcare service. The term conscience is defined to include ethical or religious beliefs, morals, or principles. The term discrimination includes adverse actions or threats of adverse actions on the basis of a professional's conscience, but does not include declining to use or purchase any service. On page 6, the bill specifies that all healthcare professionals and institutions have the right not to participate in or pay for healthcare service that violates the person's or institution's conscience, and that no professional or institution may be forced to engage in any service that violates their conscience. On page 6, lines 16 through 21, and onto the top of page 7, the bill makes clear that these protections do not eliminate a professional's already existing duty of care or erase their duty to engage in things that do not violate their conscience. Medical professionals are also not absolved of their duty to provide care in emergency situations. On page 7, lines 6 through 15, the bill specifies that the rights protected here extend to professionals and institutions that hold themselves out to be religious. At the bottom of page 7, the bill prohibits discrimination against any healthcare professional, institution, or payer for exercising the rights afforded by this act. And on page 8, the bill contains whistleblower protections for individuals informing the Attorney General or Department of Health of potential violations of the act or participating in any proceeding relating to this act. Beginning on line 18 of page 8, the bill also protects healthcare professionals who blow the whistle on any conduct that they reasonably believe violates federal or state law or regulations or standards of care, specifying that no government entity may punish a license for any whistleblower activities covered. On page 11, the bill protects professionals from civil or criminal liability for refusing to participate in services based on their conscience and provides a private right of action for healthcare professionals aggrieved by a violation of this act. And that, Madam Chair, covers the bill.
Madam Chair, thank you for this time and very, very happy to be here in person rather than online. So I agree with everything that was said there. A couple just general thoughts about rights of conscience. This bill, generally we're going to talk about providers, but this really covers all healthcare individuals, nurses, OR techs, pharmacists. And when we think about putting people into positions where they may not want to participate in a procedure, and I'll get back to that in a second. We talk about like an OR tech, a tech who works in the OR, who may be called into a position of participating in a procedure that they do not want to participate from a moral or ethical standpoint, is problematic for that healthcare employee. And so it's wide ranging. It's not just doctors choosing to not participate in some type of procedure. But really what I'd like to say is, there's a lot of questions of, do we need this? And the only rights of conscience that I'm aware of in Wyoming statute is regarding to abortion. And it's just one paragraph that providers do not, or have the choice to not participate and to not refer for abortions. This would allow us to widen this out to, different, other different healthcare entities and situations. For instance, the bills that we've been dealing with the last 3, 4, 5 years, gender affirming care, we're going to, I'm sure, be talking about physician-assisted suicide or medical aid in dying soon, abortion, of course. These are things that have, for 10, 15, 20 years ago, abortion, 50 years we've been dealing with this, but gender affirming care, we're talking about gender dysphoria, and that's gone from gender dysphoria to gender affirming care, and now we're talking about, hormonal treatments and surgeries and this and that. And we can't always, these things are going to keep coming back, and there's not going to be a way to provide, go back time and time again and provide a law or a bill to help exclude healthcare providers from participating in those type of procedures. And same thing with physician-assisted suicide. 10, 15, 20 years ago, we weren't having this discussion. And now we're having this discussion, and now it's medical aid in dying, and it's going to advance. And so this bill allows us to put it into statute right now, blanket rights of conscience. And so we do not have to keep coming back and dealing with this time and time again. And again, I really, really, really want to emphasize that this is allows for a healthcare individual to not participate in a treatment, to elect to not participate in a treatment. It is not discriminating against a patient. You cannot fire a patient. You cannot withdraw your care of the patient. It's for you are electing to not participate in a treatment or procedure, not the care of the patient. And I'll stand for questions.
Okay, thank you, Representative Ottman and Representative Bartholomew. Mr. Caldwell.
Oh, Greg's on, yay.
Welcome. We're Mr.
Chiffon.
Tough one, yes, thank you.
Mr. Chiffon, thank you for joining us. Representative Ottman and Dr. Bartholomew have introduced the bill. If there's something you would like to provide as well on behalf of the bill, please do.
Thank you very much. I thought Representative Ottman did a fantastic job introducing the bill and walking through the different pieces of it. If there are any questions on particular language in the bill, I'll be happy to elaborate on them. But with respect for your time, I think what has been already done is very good. I think the mention that this is procedure-based, not patient-based, is very important. It has to be a particular procedure, and all of the other procedures surrounding that patient still need to be provided. It's just if somebody is forced to do something that they think will harm the patient, that violates their conscience, that's when this can actually be used. And of course, it has been used in 5 other states, passed this in the last 4 years, and based on a law that's been in place since 2006. And so it's been working in other states, and it's important to know that it hasn't been abused. It's rarely invoked because healthcare professionals take their conscience rights very seriously, and they don't assert them lightly because their whole entire career is on the line when they do so. So just knowing that this is a kind of bill that does provide the kind of confidence and ethical integrity for our doctors while also working in practice as we've seen in other states.
Thank you, Mr. Chiffon. Committee, any questions of Representative Ottman, Dr. Bartholomew, or Mr. Chiffon? So we've got a few here. Representative Klauston.
Thank you to all 3 of you for your testimony and going through the bill. I guess what I'm just wondering is, have we seen this be a problem yet in Wyoming? I mean, is this just something we're looking towards the future, or we've actually had instances in Wyoming where this has been a problem? A physician has been forced to do something they didn't want to.
Who would like to take that?
Madam Chair, I can answer that.
Dr. Bartholomew.
I do not know of any specific instances here in Wyoming. I'm familiar with multiple instances statewide, including multiple medical students, as mentioned there at the beginning, medical students who have chosen not to go into specific fields because of their rights of conscience. We do have 2 residency programs here in the state, and of course the WWAMI program, and so this would afford them, students and residents, that opportunity to use their rights of conscience.
Thank you, Dr. Bartholomew. Mr. Chiffon?
Thank you. Yes, similar to that. So surveys have shown that 20% of people have changed the direction of their career, 80% of those are away from the OBGYN space, meaning you're not obviously the ethical concerns for abortion. So who suffers from that will be the moms out there that want a life-affirming doctor, will not be able to find them. And all these other states that have been passing this legislation, medical students are coming out saying, I'm looking for a state that has conscience protections to practice. Because as was mentioned, either between the corporate practice of medicine, the increase in artificial intelligence saying that this is the way that people have to practice. Students don't want to be a vending machine that are just forced to do whatever their employer tells them. So being able to put their conscience into practice when they're trying to help their clients, their patients, is very important. And as far as in Wyoming, I think so, Dr. Cuban, when you have somebody exercising their free speech rights, opining, giving a comment on the development of medical science, and then being removed from a position is something very serious. And that's not just for that particular healthcare professional who's being punished because of his free speech rights, but it also undermines the practice of medicine as a whole. Because if you don't have doctors thinking that they can actually speak up to ethical concerns when new studies come out, or when people are saying you have to do medicine this way, if people's free speech rights are blocked, you won't have scientific progress, because you won't have that important part of ethical considerations and questioning the results of studies that helps develop the science.
Thank you. Follow-up, Representative Klauston, and please direct your question. I'm not sure who you want to answer it.
Thank you, Madam Chair. Thank you again. So I guess to our last presenter there, you talked about 5 states. Can you name those 5 states for me so I can look them up? And then also the legislation that I'm looking at, is this a legislation from another state? Is this something made up in Wyoming, or is this kind of the national movement and that's where it's taken from?
Mr. Chaffon.
Madam Chair, Representative, so this is most similar to Montana's language. So Montana is one of them that passed it most recently. The other states are Ohio, Arkansas, Florida, and South Carolina. Did I give you 5 there? I think I did. And Mississippi is the state that had it originally from 2006. That's what this is building from.
Okay. Representative Yin.
Madam Chairman, and so maybe this is to Dr. Bartholomew, but I think we actually have this conscience protection in statute already. We have the Wyoming Healthcare Decisions Act, which is 3522-408, and it gives a wide berth for both the provider and the institution to decline based on policy and conscience. Is this protection not enough that we need this bill too?
Dr. Bartholomew.
I believe that falls under the advanced directives part of the statute. Is that correct? The heading of that statute is under advanced directives, and that applies to the application of advanced directives.
So,
Follow-up, Representative.
Madam Chairman, it does apply to advanced directives, but it also applies to any directive, like any specific instruction. So it doesn't have to be in advance, because the headline section says an adult or emancipated minor may give an individual instruction. So that instruction may be oral or written. So it doesn't have to be advanced. It could just be for a clinical visit in between.
Further questions from the committee? Representative Wasserberger.
Thank you, Madam Chair. I guess just a question to our presenter there on Zoom. Thank you guys for sharing everything that you've had to provide us with today. I'm just trying to imagine myself in a position where maybe I'm in a physician clinic's room and I was told by my employer that I needed to practice a certain way, and I felt uncomfortable doing that, providing that to the person that I'm trying to care for. Could you give me just some kind of story that can kind of put me in that setting? So that would, it would apply to this. Thank you.
Mr. Chaffon.
Madam Chair, yes. So a real example from Ohio who passed theirs recently, again, and this is, things come up and you can't always anticipate what the conscientious objection will be. But police brought a detainee into a hospital just a couple of weeks ago, and they asked for the hospital doctors to do a cavity search on this individual. And the doctors said this individual is in such a state that it could cause irreparable harm to the person or death. And so we cannot in good conscience do what you're ordering us to do. And so they were able to use this conscience protection to help them to defend themselves from claims that they should have done that. So that's, an example that you wouldn't particularly anticipate. But it could be, so hopefully this wouldn't happen, but a parent were asking for hormones for their child to try to change their sex or the way they express themselves, their gender, which would permanently sterilize a child. That's a sort of example where a pediatrician should be able to know, like, look, I just in good conscience think that would harm the child, or if a parent wants that for their child, if they find somebody that would actually provide that. But you should never force a doctor to do something they would think harms that child.
Committee, additional questions of the bill sponsors or co-presenters?
Madam Chair.
Vice Chair Ottman.
Thank you, Madam Chairman and committee. I'll just say a couple things. First off, there are instances of this happening in Wyoming. We have a wonderful nurses school in Riverton, and they are required to do things that they do not want to do. And I know of 6 individual young women that wanted to be nurses that would not do what was required. And it's not even a legal requirement. The other thing is we have UW and, our college, and they're required to do things that they may not want to do. And so pushed into a position, do you want to go to medical school or do you not? So there's those things. And as far as, is this bill from a different place? We talk about bills from different places all the time. When we find good legislation, we use it. I took the liberty to adjust this bill along with LSO to do what I wanted it to do. And so I don't see that as a hindrance for the bill. Thank you.
Thank you, Vice Chair Ottman. Committee, any additional questions? Representative Klauston.
Thank you, Madam Chair, and thank you, Representative Ottman. And I think I completely agree with you. Some of the best legislation has been tried in other states, and we learn from it. So, or we see mistakes that they made. But I guess that's just brings up a question. You're talking about some nursing students. So, again, we're just going to go back to the COVID-19 mask discussion. So, would this say if your employer's asking you to wear a mask and you believe you don't ethically or whatever, you don't want to, you don't have to, or is this just dealing with medical procedures? So just so everyone's clear on that.
Madam Chairman, Representative Clausen.
Vice Chairman Ottman, or
Did one.
either one of you. It looks like, okay. Mr. Chiffon.
Madam Chair, I think the correct answer was going to come from the room there. But it's not, if that is not a medical procedure, which wearing a mask is not, it would not be covered. So no, it wouldn't apply to that.
Okay. Committee, any other questions? Okay. Representative Gugamas.
So just to clarify, the stuff that we have on statute now, is that from patient perspective versus this bill, which is more of the provider's perspective? Just kind of clarifying that.
Who would like to?
I could take that, Madam Chair.
Okay, go ahead.
Madam Chair, with the code that was cited earlier before, it is under the heading of advanced directives. So somebody's saying in the future, I want these procedures to apply. And in that sense, you could think perhaps it protects the patients, whereas this does focus on not forcing a doctor to be involved. And in that advanced directives, it does talk about being able to consciously object from certain things that a patient might ask in their advanced directive. But these can also be married and work together because while there are some protections for advanced directives in that, and even if it were broader to apply to any request from a patient for a particular procedure, that bill also requires referrals, which can inculpate the person, the healthcare provider, in that medical procedure. And so this can work with it if needed. I would think that other bill just apply, the other law only applies to advanced directives. So that's why this is even more needed and necessary. But it could be, if you could phrase it that way, where this is protecting doctors from being forced into procedures. Well, that general statute, that area of law is focusing on making sure that patients can have advanced directives and have them enforced.
Okay, thank you. Committee, any additional questions? Okay, seeing none, thank you, Vice Chairman Ottman and your co-presenters. Okay. We will move on to public. Yep, thank you. So we're going to move on to public comment. Just a show of hands, how many would like to testify on House Bill 222? 1, 2, 3, 4, 5 in the audience, and I believe we have 2 online. So 1 online. Okay, so we'll move to the audience first. So are there any government agencies that would like to testify? Good morning.
Good morning, Madam Chairman, members of the committee, and happy Friday. I don't know if I really like to present in front of you on this bill, but I'll go ahead and just give you a couple details. My name is Kevin Bonenblust. I'm the Executive Director of the State Board of Medicine. As I've told you before, the board licenses and regulates practice by MDs, DOs, and PAs. And if the anesthesiology assistant bill makes it, then we'll also have AAs, so we'll have a whole alphabet soup behind us. I come here not to oppose or support this bill because that's not what agencies are supposed to do, and I'm not going to do that. I just have a couple of points I would suggest to you in reading this. And the main one is that if you turn to page 9, and halfway across the line says demonstrates beyond a reasonable doubt. That sets the evidentiary standard for saying that somebody's values, are not meeting the threshold, I guess you would say, for this exemption or this protection to kick in. I would respectfully suggest that you maybe think taking that back down to clear and convincing evidence. The beyond a reasonable doubt is up at the criminal statute, criminal violation level. That's a very, very hard target to hit. Licensing boards and so on are held to a clear and convincing evidence standard, which is lower, still very high though, compared to the preponderance, which is basically 51%, more likely than not, which is what we do in civil litigation. So I would just suggest that perhaps you change it from demonstrates beyond a reasonable doubt to demonstrates by clear and convincing evidence. And that will then mesh better with what standard is applied across the board with licensing boards and that sort of thing. As to the question of could this cause any problems, I just was thinking about it as I was driving in today, and I thought, well, let's see. There's a bill going through right now that says if you are performing a pharmaceutical abortion, you must do an ultrasound first. Now that becomes law, and unless and until abortion is completely outlawed in the state, I would posit that probably a physician could say, yes, I'm going to do a pharmaceutical abortion, but I don't believe in good conscience it's the best thing for my patient to have to see a ultrasound. I could just see that happening. I'm not saying it will, I'm not saying it won't, and I'm not saying it's good or bad. But I think this ventures into the territory that constitutional amendment that was put in place regarding Obamacare, if you will, it's turned into a double-edged sword. So I would just caution the committee to think about that as a possibility. Doesn't mean it's a bad bill or anything else, but I'm just saying that's something to keep in mind. With that, Madam Chairman, with a little bit of dread, I'd be happy to take any questions.
Thank you, Mr. Bottomblus. Questions, committee? Representative Yin.
Madam Chairman, thank you, Mr. Bonenblust. If we just strike the standard and don't put in clear and convincing, would that still hold you to the clear and convincing standard?
Mr. Bottomblus.
Madam Chairman, Representative Yin, I believe it would because I think most, if not all, of our licensing statutes, for instance, state that we have to prove by clear and convincing evidence. This would eliminate any ambiguity, though, if you pulled that out of there. So that would be helpful. You strike that language, just say demonstrates that the healthcare professionals, so on and so forth. I think that could eliminate the problem.
Committee, any additional questions for the Board of Medicine? Okay, seeing none, thank you, sir, for joining us.
You're letting me off easy. Have a good weekend, folks. Thank you.
Thanks. All right, members of the public, we've got 3 chairs up here. Please come forward. There's one empty seat, and there was quite a few hands, so if you want to testify, come forward and fill the chairs. Good morning, sir. Please state your name and whether or not you support or oppose the bill.
Madam Chairman, Bill Winnie from Sublette County. I support the bill. Oddly, I'm going to link this back to House Bill 195 that you talked to earlier and to Representative Clauston's question a little bit about whether it affects people in Wyoming. And the answer is this issue goes back 50 years. In 1976, the Navy sent me out to Idaho Falls. I was teaching out at their facilities out there. Not too long before we got there, there was a small hospital in Idaho Falls run by the Catholic Sisters of Charity, as I recall. It was a low cost, sometimes free for indigent people and things like that. Because of the Roe v. Wade decision that had occurred a few years before, they were required to provide abortions and some other procedures they felt they couldn't support. So they sold the hospital, and it became a commercial outfit. So this issue of conscience is vastly important. Second, as I understand it, there's an element in the Hippocratic Oath that says, first, do no harm. And so we're talking about, I think, procedures that may in fact cause harm. You heard testimony from Mr. Schifrin about a case where that was what was on the issue. And so when you get into these matters of conscience or not doing harm, I think this is vastly important, and that's why I support the bill. Subject to your questions, thank you.
Thank you, Mr. Winnie. Any questions for Mr. Winnie from the committee? Seeing none, thank you, sir. Good morning. Please state your name and who you're with and whether or not you support or oppose the bill. We'll hear your testimony.
Certainly. My name is Nathan Winters. I am the president of the Wyoming Family Alliance, and thank you, Madam Chairman and committee, for the opportunity for me to rise in support of this legislation. The reason such legislation, we're seeing it now in the year 2025, is that for a long time it was unnecessary. But more and more procedures are, first of all, being offered, or then people are told that they're going to have to perform them. And this has happened in several different places. And so I just want to point out, for instance, a doctor who was a whistleblower on an issue that was going on in the state of Texas. And what he was able to demonstrate is that procedures that were both illegal there and that were medically wrong, they were not appropriate for any sort of patient. This is an individual that just pointed out very carefully, not violating HIPAA in any way. He was able to demonstrate that this was occurring, and yet he was given 4 charges that he had violated HIPAA. Thankfully, that has been dismissed. But we can see that this is an important issue right now. And when it comes to the state of Wyoming, we do have situations here where it is evident that people can at least suffer because they are willing to stand up for their conscience rights. And with that, this is not adversarial at all. I want to point this out, and I've wanted to on a number of bills before, but this is a great opportunity to do so. Every year over the last 12 years, I've heard someone just ask the question whether this language is based off of language from another state. And first, all legislation you see is worked through to make sure that it lines up with Wyoming code. It's Wyoming specific. But secondly, also when it comes to the issue that we're handling, Wyoming does not exist as an island within this nation. So almost every statute you see, all the way up to and including the Wyoming Constitution, was developed after looking at how other states have handled challenging issues, designing the rule and procedure that would guide the state. And thirdly, I learned this early on with a brother who's almost 10 years older than me. I watched him as he had one night driven his truck in a race against a girl that he kind of liked. And I watched him suffer the punishment as a result of it. It's better to learn from the mistakes of others than to learn from your own mistakes. And so when we watch things happen in other states, when we watch the inevitable resulting challenges with it, it's better for us to prepare now than to wait until it's right in front of us. And so with that, this kind of legislation giving us the opportunity to access all the best from so many places. This is so important for us to pick up right now. So with that, thank you, Madam Chairman, and stand for any questions.
Thank you. Mr. Winters? Any questions from the committee for Mr. Winters? Okay, seeing none. Thank you for joining us this morning. Good morning. Please state your name and who you're representing, and we'll hear your testimony.
Good morning, Madam Chair, Committee. My name's Dr. Marcus Coolidge. I'm a family medicine residency, about to graduate in about 6 months. I went through the great medical school here in the state and have some close ties to the residency programs in the state as well. I am really glad to be here. I'm a little nervous, if you can't tell. I've got to listen to you guys. It's a good opportunity. It's something I love about the state. I'm originally from Casper. My mom's a doc here. It's my home. I understand the intent of this legislature, and I understand the protections it's attempting to provide to me, but I actually stand in opposition of this bill. The U.S. Department of Health and Human Services, Office for Civil Rights already protects us on a conscience level, and the like our medical ethical code also honors conscious objection, which we hold incredibly high in our own self. I think I heard a little bit about this is going to affect or help with recruitment to the state in terms of future physicians. And that's something I think I'd also push back on. Like I said, I just went through the medical school program here. I have a lot of close friends there. It's a program of 20 people. I know them well. I know the classes below me well. I know the classes above me well. I know the medical students that are currently going through that program well. And I would tell you that I can feel pretty confident that most of them would oppose this legislation. I don't have numbers, but if you would like them to email you or reach out to you, I am happy to do that as well. And that is talking about recruitment from this state, from physicians that are from here and that want to be here. I think my biggest concern with this bill is that it lacks protection and transparency for patients. If I'm to refuse care on a conscience level, I don't have to disclose that to the patient that I'm refusing certain care. I don't have to disclose that, like my rationalization for my recommended medical course. It allows me to, I think it really undermines the patient-provider relationship that we try to create, because I don't have to be transparent with what's going on. And I think a huge part of being a provider is like shared decision-making, where we talk about risk, benefits, and opportunities for patients. And so they talked a lot about procedure. I don't argue that no provider should perform any procedure or nursing staff or surgical tech except in medical emergencies, which this talks about. But this is covering all healthcare services. This means someone could come to me with a substance use disorder and I could see that as a moral failing, which I don't, but we have good medicines to treat substance use disorders. I could not offer them any care. I could decline that. Same with mental health services, same with metabolic syndromes. It's too much, and I think it takes away some of the autonomy that exists for patients, and that's a little bit concerning to me. Yeah, I think that's everything I have. Thank you. I appreciate it. I stand the question.
Thank you. And that was, your last name was Coldridge, right?
Yes.
Okay, thank you. All right, committee, any questions of Dr. Coldridge? Representative Wasserberger.
Thank you, Madam Chair, and thank you so much for being brave enough to come and share your testimony with us. Just a question of the concern of the lack of transparency. Now, if you decided conscientiously that you didn't feel comfortable to provide a substance use disorder treatment for that person, wouldn't you be able to explain to them why you didn't feel comfortable with it and maybe refer them to somebody else? I don't know, just again, thank you for coming and sharing your side of the story.
Dr. Coldridge.
Madam Chair, Representative. This is theoretical. I would. I think the concern is just like the reason that this bill was created, and I fully respect, is for things like abortion, gender affirming care. But it covers so much. So we can still, like, if someone comes to me and again, theoretical, if I see someone who uses substances as a moral failing, I don't think that they necessarily deserve treatment for that. I don't have to tell them alternatives. I don't have to tell them like other medications. I don't have to tell them other resources to be able to go and seek out that case. Same thing for mental health services. It's for any service. I don't have to be transparent about why. I would hope that most providers would be. I would hope that we would stick to our ethical code and but the whole point is that we are already held to a standard by the Health and Human Services, and we're held to standard by the medical board and by like our own Hippocratic oath. And so this gives us kind of a blanket protection where we don't have to do any of that. In my reading, I'm not a legislator, I don't know the legal, but that is how I interpreted this bill.
Thank you. Additional questions? Okay, seeing none. Thank you for joining us this morning. Sir, please state your name and who you're with and your take on the bill.
Yes, thank you very much. My name is Tim Thornell, President and CEO at Cheyenne Regional Medical Center and a board member of the Wyoming Hospital Association. While we certainly support, physicians, hospitals, caregivers of all types being able to make decisions about the care that they're providing, and we always want everybody to act in a manner that is consistent with their beliefs, we also fervently believe that those are already codified in both federal and state statutes. As previously mentioned, statute from the state side, 3522-408, obligations to healthcare providers, while it is under Chapter 22, Living Wills, how it is described there and further under definitions allows that for clearly to be interpreted as conscious decision to not do something outside of just living wills. It's pretty clear. Our in-house counsel has vetted this quite nicely and has assured us that that is all encompassing in the bill that's already there. So we believe the protections that need to be there exist, both federally and statewide. Our concern about the bill as it currently stands is that it is very broad and opens up some challenges for all healthcare providers, particularly hospitals that have emergency rooms. And as patients present in our emergency rooms, we are subject to a whole host of federal regulations, including EMTALA, the Emergency Medical and Active Labor Act, which has been around for over 40 years. And we have an absolute obligation to treat every patient that comes into our emergency room for emergent care and life-threatening care. And if you think of smaller hospitals, Cheyenne Regional, we're larger, but there's quite a number of the 17, 18 critical access size hospitals across Wyoming who may only have one provider in their emergency room at any given time. And if they want to object, as the gentleman from to the left of me earlier said, I don't, you're here and I don't agree with how you found your way here. It's through, you're here by a drug-induced instance. I don't believe in that. I'm going to step back. There's no one left to take care of them. And we have an obligation as a facility to provide care. So it really puts hospitals in a really precarious position, bumping up us against EMTALA regulations there. And again, I think the main crux of what we're trying to achieve here already exists both federally and statewide. Thank you.
Thank you. Any questions of Mr. Cornell? Representative Clauston.
Thank you, Madam Chair, and thank you, Mr. Thornell, for being here this morning. I thought it said in here, but I'm not finding it, so maybe we need to add it. But if we excluded emergency room care from this bill, would that be acceptable to you?
Mr. Cornell.
Madam Chair, Representative, I think that would be helpful, but we also recognize, emergency-related services occur all throughout the hospital in different forms or fashion. It could be in our ICU and a code happens, and in different instances, we may only have one provider of that specialty that can do this service. We can find that in obstetrics and just other, doing C-sections. Those emergency situations can be found outside the emergency room. So while it would be a positive step, it wouldn't, I don't believe, solve the entirety of the challenge that we would face as a hospital.
Any additional questions? Vice Chairman Ottman.
Yes, thank you for being here today. One of the things that I was looking at, you said you think we already have protections and that it's not needed. There was a survey done of 1,732 members of a faith-based medical association. 23% reported personally experiencing discrimination. 36 reported facing pressure or discrimination from medical school administrators. 20% said they decided not to pursue a career in certain fields due to a lack of tolerance. 91% reported they would rather stop practicing medicine than be able to force their conscience. Did you see in this bill anywhere where a person was not able to say at the very beginning of their tenure, or where they went to school, or what office they worked in, or whatever, that they couldn't go in at the beginning and say, it does say in here too that it is written and it is a code of their particular office or whatever to do those things. This is not about the patient, this is about the medical providers. And I would just challenge you with EMTALA. It is hospitals and hospital-affiliated standalone emergency departments are required to provide examinations and treatments to anyone with an emergency medical condition. This bill would not conflict with that. And once again, this is for providers to go into the specific realm of medicine that they would like to go. It's not just for anybody. So those things would have to be considered on the front end. And we also do have doctors that have been fired for showing their medical conscience and about certain things, or even voicing an opinion about that. So how do you see that it's already covered and that it's not needed?
Mr. Caldwell.
Yes, thank you, Madam Chair, Representative. Again, I think it says that the study you referred to clearly is not a Wyoming-based study. It can't be with that magnitude, and refers a lot to medical schools and training, none of which occur on the medical school side. You know, here in Wyoming, we have a very abbreviated program in conjunction with the University of Washington. So I think you're looking at a different scope through that study. But again, our statute 3522-408, a healthcare provider, it really does talk about providers, not the patient side of things. So providers can object to that conscious objection. So again, I still assert that that exists for the providers here in our state.
Follow-up, Vice Chair Ottman.
Thank you, Madam Chairman. I would just push back, as far as the study being for other doctors, we're looking constantly, as far as I know, for providers from other states and different places to come here, to go to the schools and then stay here. So this does apply to people around the board. And I have to push back with you. This is not for every doctor. This is for people. In the military, we have people that didn't serve or didn't fight because they had an objection to doing that. But nevertheless, they served as a medic or maybe in the kitchen or whatever. So this is not to discriminate against someone working. This is to provide their First Amendment rights of conscience to do what they would like to do in their field of expertise. Thank you.
Thank you. Additional comments or additional questions, Mr. Caldwell? Representative Gugumas.
Thank you, Madam Chair. In regards to your emergency room services, I believe that's addressed here on page 7, on line 1 through 4, Romanet 3, not to be construed to waive or modify any duty of a healthcare professional or healthcare institution to provide other healthcare services or emergency medical treatment under 42 USC. So I believe that is addressed in this bill.
Any questions for Mr. Caldwell? Okay. See none. Thank you, sir, for joining us this morning.
Thank you.
Please state your name and your thoughts on the bill.
Thank you, Madam Chairman, committee members. Eric Pulley with Wyoming Hospital Association. I think my good board member here, Mr. Thornell, did a great job of talking about their experience at CRMC. I think I just have a few questions and maybe a little bit more context to some of the things that have been said. If we're trying to address specific problems, which I think we've stated, there are 3 specific instances here: physician-assisted suicide, abortion, and gender-affirming care. This bill's too broad. And I can see situations, and this doesn't just cover physicians, this covers anyone that works in our hospitals. So if we have a nurse that's assisting a provider on something blood transfusion or something else. They could say they consciously disagree with it and refuse to give that care. If we want to address what we want to address with this bill, let's make it specific to those specific things and not make it so broad. I think it creates unintended consequences and challenges for us to understand what the bill is trying to do. The example that was used by the gentleman with the policeman bringing someone in that needed to have a body cavity search, the physician could refuse that. It's not medical necessity. It's not like he's being forced to do it, and he could say no, especially if it's not safe for the patient already. There are already safety nets in place for a lot of these decisions that are being made. When we listen to Dr. Bartholomew, who I really respect a lot, and he says that people are leaving because these protections aren't in place, I would tell you, and in your own communities, we've seen this, we're losing OB services in our state because of the laws we've already passed. We have folks that are concerned about some of the abortion bills and some of the unintended consequences and how deeply it gets into their practice that are not coming here to practice OB services. And so it's not because they're not protected, it's because, it's not because they're not protected by something like this. They're not protected because there are things that they do to save women's lives that are already in jeopardy and that they could be prosecuted for. I'm interested, at what point when we are employed by an employer, at what point do we honor that contract and work? You just passed a bill on off-label prescription use. And in that, we've given autonomy to the providers to do whatever they want. And I would tell you that the examples you've heard in our state, it's a much bigger story than what you've heard. But as employers, we can't talk about reasons that people are terminated. But there was already the ability to use off-label drugs. And we passed a law to force that and to protect providers. When are we going to protect the employers? When are we going to look at using internal policies and procedures? The one thing that I would say is if I'm going into a practice, I would find out what practices are going to be done in those institutions and in those practices. Are we going to do abortions? There's only one facility, one hospital in our state that I think provides abortion services right now. Not aware of too many, if any, that do gender affirming care, and there are no physician assisted suicides right now. But if we want to address that, let's address that in the bill and not make it so broad. And with that, I'm willing to answer any questions. Thank you.
Thank you, Mr. Bully. Representative Wasserberger.
Thank you for coming and sharing that. I think kind of the reason why this conversation's probably gotten started is, right after 2020 and the COVID pandemic, there's all kinds of stories of the state banning uses of things like hydroxychloroquine and ivermectin. And, I was taking that stuff and having to go across the state line to go get it because I couldn't get it here. And I never got COVID during that time by taking that stuff. And so, as far as protecting the employer goes, if you've got somebody that's running a pharmacy, so I guess I'm moving the subject here a little bit, but, if somebody owns a pharmacy and they don't feel safe giving people those vaccines, but, you've got somebody up above them saying that we're going to shut down your pharmacy if you don't provide those for people. Is there any type of protection in place for those type of employers if they're sitting there going, I don't want to recommend this to people?
Mr. Bully.
Madam Chairman, Representative Wasserberg, I'm not sure I exactly understand the question with the pharmacy example. The pandemic was a learning experience for most of us, and we're still learning from it. I would tell you that the state did make some of those drugs available, and we were working with our members to get some of those drugs pushed out. Ivermectin's a different situation than hydroxychloroquine, but we helped get hydroxychloroquine distributed around the state, and the state helped us with that. As far as the pharmacy, I'm not really sure I quite understand the question. I'm sorry.
Okay, follow up, Representative Wasserberger.
I guess, so an example, this is next state over, the person I know that had to do this, but he was somebody that was just refusing to recommend the vaccines for people, and he ended up losing his employment over that. And so, you know, I guess this is a pretty tough thing, and I don't even know if I'm going to be able to explain this question in a way that makes sense. But is there, if somebody owns a pharmacy and they just absolutely are not going to, you know, order like a vaccine for that COVID thing, or they just don't feel that it's safe, and they're getting threatened up above from the next person that they're gonna, or the government for that matter, that their pharmacy would be shut down for that. Is there any stipulations in place to protect that person that's running that pharmacy if they don't feel comfortable providing that vaccine?
Madam Chairman,
Mr. Boley.
Representative Wasserberger, I would say that if they own the pharmacy, they can do whatever they want. If you belong to a chain of pharmacies and it's a corporate decision, then I think you'd have to do what the corporation says. And as far as federal overreach, there was a lot of it during the pandemic. And this body's pushing back right now. They're putting us in the middle, but you guys are pushing back against it. That's great. This is totally different though. I really believe that if we want to address specific elephants in the room, from your perspective, let's do it in this bill, but let's not make it so broad.
Okay, additional questions? Representative Colston.
Thank you, Madam Chair, and thank you, Mr. Boley, for being here. So, one of my concerns with maybe this and other legislation is the financial situation of a lot of our facilities in Wyoming. Can you tell us kind of where a lot of our small hospitals sit and how this might affect their financial situation?
Madam Chairman.
Mr. Boley.
Representative Clauston, thanks for the question. Our hospitals right now most of them are in pretty poor shape. Our critical access hospitals, every single one of them are operating on net losses. Their margins don't exist. And as we take a look at some of the things that are going to transpire or could potentially transpire with property taxes and no backfill, we're going to see drastic cuts to the services that we're able to provide in our communities. So every one of our critical access hospitals, along with our bigger hospitals, are going to be impacted significantly by loss of revenue from their taxing authority. Adding additional burden, whether this equates into legal action or whatever it might be, everything we're doing right now is just adding to the cost of healthcare and our inability to keep pace with that, with reimbursement rates and other things that we're seeing. We're seeing potential ratcheting down of Medicare rates, reimbursement from the federal government. They're taking a look at how Medicaid's going to be paid. They're looking at block grants. I mean, we're in a different realm, but our hospitals are struggling right now. And any additional administrative burden and expenses is just exacerbating a serious problem.
Any additional questions of Mr. Boley? You've seen none. Mr. Boley, I have two for you.
Okay.
So based on your testimony, you referenced the practice of OBGYN and three concerns that you had in this bill. You serve on several committees and boards and community groups, and I was just curious, when you talked about the shortage of OBGYN practice, can you tell me whether or not medical malpractice insurance and the cost of that comes into play with the shortage in Wyoming? And then my second question, I'm just curious if you polled your members on this bill.
Thank you, Madam Chairman. As far as malpractice is concerned, malpractice is expensive, very expensive. And obviously, we've talked about tort reform over the years, and we never really get that off the ground. I think the thing to realize is that a large percentage of our physicians right now are employed by the hospitals. So the hospitals are picking up a lot of that malpractice insurance. But for those that are in independent practice or have a conglomerate, it's expensive for them. It definitely is. I'm not sure this bill would feed into that. I mean, this is just a matter of addressing those issues. as far as polling my members, yes, our members are very concerned about this because of how overreaching, or how broad the net is on this.
Okay. Any additional questions? Seeing none, thank you both gentlemen for joining us this morning. Any additional public comment? Mr. Winnie, I apologize. Just like to give everybody one bite at the apple. Thank you, though, for your willingness. Okay, and do we have somebody online? Okay, bring her in. Welcome, Ms. Shaver. Please state your name and your stance on the bill.
Good morning. My name is Marcy Shaver, resident of Goshen County and the Wyoming State Director for American Atheists. We see this as an intrusion of religion into our laws, and mainly because it allows people to put their religious feelings above the care of their patients. Strongly opposed to this bill. Happy to take questions.
Thank you, Ms. Shaver, for your testimony. Committee members, any questions of Ms. Shaver? No? Okay, seeing none. Thank you. All right, committee, I am going to close public comment on House Bill 222. Obviously, we're close to 10 o'clock. I will ask what the committee's pleasure is. If the committee chooses to move the bill, we will carry it over to the next meeting to work it. So committee, what is your pleasure? House Bill 222 has been moved by Representative Gugamas, seconded by Representative McCann. We will carry the bill over till Monday, and committee will discuss and work amendments on that. So with that in mind, we are adjourned.